Okay, let's get started. It's 10 o'clock and we have our next speaker ready to do their presentation of their poster for the 2020 Celebration of Scholarship. And so we have Alyssa Munar ready to talk, and she's going to be talking this morning about medication-assisted therapy for opioid use disorder. So I'm going to close my screen and turn it over to you.
Okay. Hi, everyone. I want to thank you for attending my presentation today on medication-assisted therapy for opioid use disorder. My name is Alyssa, and I'm a current MEMS student. And for the rest of the presentation, I want to go ahead and refer to medication-assisted therapy as MAT. And then I want to refer to opioid use disorder as OUD. I'm going to give a little bit of background information first. So I'm sure as everyone's aware, the current state of our country, we are suffering from an opioid epidemic. It's estimated that over 4.3 million people aged 12 years and older reported using some form of pain reliever for non-medical purposes. And when we talk about treating these people, 96% of states suffer from a gap between the population diagnosed with opioid use disorder and the MAT capacity that we have to treat these people. And this is most likely due to a rapid increase in the patients that we've seen being diagnosed with opioid use disorder. So in the last 15 years, we have seen a 900% increase of patients needing a form of MAT to be treated for opioid use disorder. What exactly is opioid use disorder? Opioid is a term that includes not only prescription analgesics such as oxycodone and hydromorphone, but it also includes byproducts of the poppy plant, which is things like opium, morphine, and codeine. And these have highly addictive properties, and when taken, they can rapidly progress to physical dependence and drug tolerance. So after long-term use of these drugs, the patient needs to increase their doses in order to achieve the same desired effects. And these desired effects can include things like reducing their pain level, chasing a feeling of euphoria, and also a feeling of tranquility. And when taken in large doses, they can lead to overdose and severe respiratory depression and even death. The Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, defines opioid use disorder as the recurring use of opioids within a 12-month period with at least 2 of the 11 diagnostic criteria. And the diagnostic criteria includes things like withdrawal, cravings, and opioid-seeking behaviors. And based upon how many of the criteria the patient presents with is how they are diagnosed from mild to severe. So 2 to 3 criteria is considered mild, 4 to 5 is considered moderate, and 6 or more is considered severe opioid use disorder. And tolerance and dependence were actually removed from the DSM-5 criteria due to these being inevitable consequences of opioid use disorder. When we're talking about treatment for these patients for opioid use disorder, it really is an individualized process. It needs to be holistic, and we're looking at not only the patient's drug habits, but also the psychosocial and cultural factors of their life. And the complexity of treatment really remains high due to the chronic, multifaceted nature of opioid use disorder. And patients suffering from OUD can go into remission. However, the risk of relapse is very high due to the chronic nature of the disease, and it's considered a normal part of recovery for the patient to relapse. Now, the process of treatment typically begins with a medically supervised detoxification, followed by a maintenance dose of opioid substitution therapy. And this substitution therapy is a prescribed amount of long-acting opioids in order to prevent cravings and withdrawal symptoms. Now, the idea behind prescribing them a long-acting opioid to treat opioid use disorder is to diminish the patient's symptoms and then eventually wean them off of this drug However, the process of weaning is very challenging, and some patients need to be on this substitution therapy for long periods of time and even a lifetime for some patients. I'm going to briefly describe the 3 forms of FDA-approved MAT that were explored throughout this literature review, and they are buprenorphine, methadone, and naltrexone. And buprenorphine is a partial agonist, and it acts as a substitute in the brain for the opioids to block these cravings and withdrawal without the actual euphoric effects of opioids. It's applied in 3 sublingual forms: an extended release form, which is subcutaneously injected monthly, and then it's also a combination form of buprenorphine naloxone, and it can also be in an implant form if the patient is clinically stable. The next one is methadone, which is an opioid agonist, and this needs to be prescribed through a methadone clinic, which is a special federally approved treatment program, and the patients must show up daily in order to receive their doses. Naltrexone is the last drug. It's an opioid antagonist, and it blocks the euphoric effects and analgesic effect of opioids and cannot be initiated until the patient has fully detoxed. To improve the adherence to this drug, the FDA approved an extended release form, which can be subcutaneously injected and offers the patient a long-term dose from anywhere to 1 to 7 months. The purpose of this review was to explore the literature which presented treatment outcomes in studies which use these 3 FDA-approved MATs as their primary treatment. So the 2 main variables that were explored were synthesized for the purpose of this research. And they were called treatment persistence, which was defined throughout the process as variables or concepts such as treatment retention, treatment adherence, continuing with the prescribed program, or simply completion of the study. And rates of relapse was defined as the return to use of opioids, which incorporates outcomes in the study such as positive urine screening, dropping out of the treatment, failing to show up to follow-up appointments, or fatal overdoses. Now, in order to find these studies, databases were searched, and they included CINAHL, PsycArticles, PsycInfo, and PubMed. The key search terms included combinations of opioid use disorder, medication-assisted therapy, treatment, and treatment outcomes. The articles included were from 2016 to 2019. There was any form of MAT included. It didn't matter how the drug was administered, so it could have been sublingual, oral, subcutaneous. Settings were limited to outpatient settings, and pregnancy and adolescence were not included because these are 2 special populations which should be treated differently than someone who's not included in that population. So the conclusions or the various treatment persistence rates and the rates of relapse are presented in the table on the poster, as well as the number of participants that were included in the study and the time in which they measured the various outcomes. And the conclusions for each drug were synthesized based off of these rates presented, as well as the characteristics of each drug and factors that could have influenced the treatment, like how long they took to measure or how the drug was administered. Conclusions for methadone included treatment persistence rates ranging from about 11.9% to 74%. And there were 2 studies that assessed methadone treatment retention in alternative sites, which included telemedicine and on-site pharmacy. So the treatment persistence rates, which was measured for the on-site pharmacy, was about 11.9% versus a community-based pharmacy, which was about 57.3% after 1 year. And then the telemedicine treatment retention was about, or treatment persistence was about 50%, while the inpatient persistence was about 39%. So based off of these 2 studies, it's a possibility that high treatment retention and convenience for which the patient gets their prescription do have a correlation. And this could be attributed to the fact that methadone is highly regulated. So the patient has to be closely monitored while they're on methadone. And this is for several reasons. Methadone itself has sedative effects, which may actually become euphoric to the patient. And it has possible severe side effects like respiratory depression or overdose if taken with other opioids. So initially, higher treatment persistence rates could be attributed to the drug's ability to initially block those withdrawal symptoms. Because if a patient stops taking this drug, they will experience withdrawal symptoms, and this will most likely motivate the patient to return to the use of opioids. Buprenorphine persistence ranged from about 39% to 95.3%, and the study which concluded the 95.3% was measured after 3 days, which is not exactly an accurate indicator for predicting long-term treatment persistence. However, the treatment persistence was still higher for this drug than when comparing to other mats. It averaged about 61.7% at around 29 weeks. And this could be attributed to the drug's ability to reduce the cravings and the withdrawal symptoms. And there also is a lower risk of abuse with buprenorphine when compared to other mats, and this is because of the ceiling effect, meaning that the agonist effects that buprenorphine has increase as the dose increases. However, these effects eventually reach a plateau. The next drug looked at was a combination of buprenorphine and naloxone, which is also called Suboxone. And the treatment persistence ranged from about 46% to 91.8%. And this really high treatment persistence rate of 91.8 was once again measured after 3 days, which is not an accurate indicator of treatment persistence. And the average for Suboxone was much lower when comparing to other FDA-approved forms. So despite naloxone giving this form of drug a higher safety profile, patients may be more reluctant to take this form of the treatment. And this could be attributed to the chronic nature of opioid use disorder and knowing that relapse is going to occur. And if relapse does occur, the patient will experience withdrawal symptoms rather than the euphoric effects from the opioids in which they are trying to achieve. So the possibility of the patient experiencing withdrawal or the knowledge of these effects could deter a patient from choosing or remaining on this form of the treatment. The next two that we looked at were the buprenorphine implant, the Probuphine, and the extended release buprenorphine. So these both offer an alternative form of treatment, and the persistence rates ranged from about 41.3% to 85.7%. And the study with the high treatment persistence of about 85.7 attributed this to the smooth transition from sublingual buprenorphine to the implantable buprenorphine. So the patient has to be clinically stable on their sublingual doses before they can switch to the implant form for a minimum of 3 months with no dose changes. So it's really important that the prescriber is aware and needs to make sure that these patients are highly motivated to remain abstinent because of the fatal side effects of buprenorphine if taken with opioids. And the last drug looked at was extended release naltrexone. And the persistence rates ranged greatly on this drug. It was from about 3% to 76%. And the 3% was measured after 1 year of treatment, while the 76% was measured at about 6 months. And one study concluded that 47% of the participants still present at the last time point, averaging less than 6 months. And the reasons for why the patients are staying on this drug for less than 6 months are really unclear. And so it could be concluded that the longer the patient stays on extended release naltrexone, the more likely the patient is to relapse. And there are variables that contribute to a lower treatment persistence, which include things like experiencing anhedonia, anxiety, restlessness, and concurrent use of other substances. And there are also variables which are protective against treatment persistence, which include things like being married and a stable employment. So it's possible when patients show up for treatment that they have some of these protective factors, but it is also most likely that they don't have these factors, which increase treatment persistence. So long-term abstinence may be more difficult to achieve because the patient is wanting to get that euphoric effect that they crave, and they need to discontinue extended release naltrexone before doing so. So how are we as nurses using this information? Nurses are in a strategic position to help address substance abuse problems in patients. We need to be implementing abuse screening and assessment programs into our routine nursing care. And nurses are the healthcare provider that's most seen by the patient. And we can provide education on safe use, disposal, and storage of opioids. Nursing requires skills and recognition of the importance of starting an appropriate pain treatment plan. And we have a good understanding of both the current medication use of the patient and the medication history. So improving the delivery of opioid prescription education at discharge might enhance the patient's knowledge and promote proper use. Correcting the educational methods might help mitigate the opioid crisis by reducing the rate of opioid use disorder and accidental overdoses. Nurses can look for specific signs of drug misuse, and this could include things like asking for more opioid prescription before it is finished, repetitively stating that opioids were lost or stolen, not attending regular follow-up visits, and calling the clinic or heading to the emergency department seeking more opioids. And we can also offer alternative forms of pain relief for patients. So overall, when we're looking at the 3 forms of FDA-approved MAT, they all do demonstrate an ability to keep the patient abstinent for a certain period of time. However, these therapies are not a one-size-fits-all treatment, and a multitude of factors need to be assessed before starting a MAT therapy. And despite extensive research being done supporting the use of medications for OUD, there's still a lack of understanding of how these medications work over long-term treatment. And in order to improve knowledge about the treatment, research needs to be done to help patients who don't respond to the traditional form of treatment. And future studies should take into account patient barriers to treatment, such as availability of the treatment, cost effectiveness, and also how far these patients are traveling to things like their follow-up appointments or the methadone clinic. And then before I go into any questions, I would like to say a special thank you to Dr. Joe Carter and Dr. Amy Yates for their continuous pushing me and supporting me throughout this process, because it probably wouldn't have gotten done without all that.
Excellent, Alyssa. And, I think your thinking, your chair and your reader is especially meaningful in this time of stress as we all try to finish up this semester. So any questions from our viewing audience today?
Alyssa, it's Dr. Fike. Not really a question, but just a comment. I've taken care of a lot of patients at the hospital on the methadone programs. They come in for other reasons, of course. My perception was they're very anxious people. The first thing they ask about when they get admitted is getting that methadone available and when it's scheduled, and then they wait for it every day and very, very anxious about their program. They don't want it to get messed up by the hospital processes.
Right. And you're exactly right. These patients, they have the fear of experiencing that withdrawal and they don't want to go through it. And so they are really adamant about their medication, because if they don't get it, they're going to relapse. And when they experience that withdrawal, that will push them to want to use again. So you're exactly right.
Hey, Alyssa, it's Miranda.
Hey, Miranda.
I know that you are interested in psych nursing, so I think that this is actually, I think psych has a lot to do with opioid dependence and that sort of thing. So
Sure.
how do you plan on, or more, I guess, how will this research that you did inform your practice as a nurse in the future?
Sure. So I've been in contact with Crossing Healthcare and just like where the gaps in the research actually are. And the gap is really how are we treating these people long term? And what are the barriers to this? So we have areas in our country right now that don't have access to these types of medications. And so the research needs to be put out there as to what is the most effective so we can be treating these patients in the most effective way. And so I think that was the whole purpose of my project, was to get some of this research out there and say, okay, well, based off of these rates, this is why this could be happening.
Awesome. Thank you.
Great job, Alyssa. This is Joe. So if you had, I just have to ask, if you had a person that you were really close to with an opioid use disorder, what would you recommend to them as a first step?
Okay, so as far as treatment, it's hard to say, what medication I would prescribe, because there's a lot of factors that go into it. So I would ask, do you have car rides? Can you drive yourself to the clinic? Are you willing to go through detoxification before you're taking your drug? So I would be asking questions like that, but ultimately, there's not really a right answer to that. It's patient based. And so as long as the patient has the ability to show up to the clinic and get their doses, I would say that it's more important to look at their treatment long term, meaning we need to set them up with a job, and we need to make sure they have the social support to get these resources. I wouldn't say it's more the drug or the medication assisted therapy. It's more the holistic process of treatment. So, I don't really know what drug I would advise. It's more like you have to look at everything.
It's infinitely more complicated than, I think most of the lay public just think, oh, there's a magic bullet and it'll make it go away. And it's really not the case. So thank you for talking about that.
Mm-hmm.
Alyssa, this is Amy. Nice job.
Thank you.
I think we also need to be very aware of our own biases and judgments about this population, because it's so prevalent on the forefront of America socially that I think I have a couple clients myself who are being denied their pain medication by their PCP because of the opioid crisis. So I think Alyssa touched on it, that we have to be extremely individualized in our plan of care, very thorough health assessments, social history, previous, substance use, social support, all those things. So this is a population that I think the self-assessment of the healthcare professional is very critical.
Oh, absolutely. I completely agree. And just knowing that there are so many ways that the patient can try to gain access to opioids. They can go through the emergency department or, another care provider like a dentist and try to gain use of, a hold of these opioids. And it's more than that. It's a chronic disease that these people are suffering from. It's not just drug seeking. It's more than that.
This sounds like hey, this is Dr. Bentley. You did a really good job, Alyssa.
Thank you.
This sounds like a perfect nurse-led clinic and case management project.
Yeah, I actually have been in contact with people over at Crossings, and so I'm really interested to submit this to them and see, what they say back to me, because, it was kind of the whole reason why I got into this.
I think Dr. Yates' point too about this affects all different practices that we might engage in terms where we're all going to run into someone with an opioid use disorder. And I agree that, you know, pain management, we need to be particularly sensitive to. They need to have their pain managed as best as it possibly can be. And you know, check our biases about all of this. So,
yeah,
because they're suffering, so.
Yeah, absolutely. I was reading a lot about just opioids being prescribed in like a cancer setting, and it's hard to tell those people you don't need this. And so it's almost like we as healthcare providers need to be more educated in order to teach our patients about alternative forms of pain relief.
Yeah, go ahead.
Alyssa, it's kind of interesting. One of the MEM students behind you is looking at stigma of mental health disorders. And she has found a wonderful a nursing model to kind of look at this whole issue. So you might want to have a conversation with her at sometimes. It's Alexa, so.
Oh, okay. Yeah, that'd be interesting to hear her perspective on what she thinks.
Yeah, Alyssa, I was going to say, I feel really bad for this population of people because they come in, you know, with acute pain problems and they don't get very much pain medicine prescribed for that because of their backgrounds and their history. Yeah. And I have fought for these people to get better pain control, and the providers just will not work with you on it. You just get, you know, flat out told no more. And so you have to fall back on the non-pharmacological interventions as a nurse because you don't know what else to do.
Right, exactly. And it's hard to tell someone, no, I can't give you your pain medicine when, you know, you can see it in their face, they're in pain. It's hard to tell someone that.
Nice job, Alyssa.
Thank you.
Good job, Alyssa.
Great job.
Thank you.
Great job. So we will close this session, and our next speaker will be at 11 o'clock. So we have a little bit of time for everybody to stretch their legs and maybe step outside their doors for a breath of fresh air. So see you in about a half hour.
Thank you.
Great job.
Good job, Alyssa.
Thank you.
Good job.